Good afternoon. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. We have the pleasure of hosting the WFNS-CAA collaborative efforts on pediatric brain tumors, and he has an all-star cast assembled. And I'd like to introduce Llewellyn. Hello, Llewellyn.
How are you, John?
Okay, it's all yours, Llewellyn.
Thanks, John, for the introduction and these webinars. I'm going to hand over to Mohammed Al-Beltaghi. We organize these together on behalf of CANS. I'll just briefly welcome Nasser Al-Gander, Modi Qureshi from CANS, who we're delighted to have. Mo, you want to take over the introduction?
Yes, hi everyone. It's our pleasure to have you in this webinar series for pediatric neurosurgery in the CANS. This pediatric series, we have this time 3 eminent speakers actually. So we'll start with imaging in pediatric brain tumors with Professor Dr. Bahatia. I will hand it to Llewellyn to introduce Dr. Bahatia and his presentation.
Okay, thanks, Mo. So our first speaker is from CHOP at the moment, as we've learned he's 2 days into his CHOP experience. Hey, Ashim? So Ashim Bhatia is a pediatric neurologist with current research focusing on the use of advanced imaging for monitoring treatment efficacy in CNS tumors. Completed his fellowship at the Children's Hospital of Philadelphia in 2015, and he's currently assistant professor in radiology at the Children's Hospital of Philadelphia. He's an active member of the American Society of Pediatric Neuroradiology, and his most recent project is focused on sodium MRI to provide a beneficial imaging biomarker in pediatric brain tumors, particularly in determining tumor progression and pseudoprogression. So Ashim, it's a real delight to have you speak on imaging in brain tumors, which you know is sort of fundamental in all our decision making. So I'll hand over to you, Ashim, if you want to start sharing your screen.
All right, thank you for the introduction and thank you for the invitation, Dr. Mohammed Al-Beltaghi. So I really appreciate the opportunity to present here. And with the time, I thought it would be best to focus on a specific tumor, and then we'll go a little bit diving a little deeper into those details. Just make sure everything is appearing okay on your side.
Perfect.
Yes, perfect.
Yeah, so like I said, I've been here at Children's Hospital Philadelphia for a few days now, and great institution, and it's happy to be here and happy to present on this topic. So we'll dive deep into the genomics, imaging, and some of the prognostic information. Disclosures, I'm a consultant for Group A. And here's the outline. So we'll go into the background, some of the history. We'll go into a much more detailed discussion of the subgroups because the World Health Organization just released a 2021 classification. And so I had some of that information before actually presenting. And this presentation was prepared, but just a few weeks ago, the release of the 2021 classification came out. So I'll include some brief info there. I already had a lot of that included, and then we'll go into just a brief discussion of syndromes related to medulloblastoma predisposition. And so this is just a breakdown of the most common tumors by age, and this is within the United States. You can see the 0 to 4 age group, the embryonal tumor is the most common. And within the embryonal tumors, you have medulloblastoma as the most common tumor, which is about 63%. And that's why this topic is very important, I think, is because it is the most common high-grade or malignant tumor, especially in the younger age group, you can see that. And we'll look at another statistic here. So I was actually trying to research within regions of Africa, what statistics are they similar to the United States, because this slide here is United States statistics. This study was out of Morocco. It was very striking that out of all the patients, so out of 542 patients, about 29% of them had confirmed pathology of medulloblastoma. So that was the most common tumor out of this study. And this is out of Morocco specifically. And then the next most common was polycytic astrocytomas and other low-grade astrocytomas. So just shows the importance of us understanding medulloblastoma. Like I said, for quite a while, I was showing this slide as the new 2016, was there was a CNS update in 2016. And now the 2021 classification is out. So we can say new 2021 classification. And we'll go a little bit into those details, but it's important to know that the World Health Organization releases blue books more frequently. The plan is to have them more frequently over the next years, in the future. But the first one actually came out in 1979, and then there was interval releases in 1993, 2000, 2007. And this was a CNS update, so it wasn't an official blue book, but a CNS update. And now, like I said, 2021. And what the 2021 classification, here's the article that just came out in Neuro-Oncology. It breaks down medulloblastoma into this classification. So you have medulloblastoma Wnt activated, medulloblastoma sonic hedgehog, TP53 wild type, and then also sonic hedgehog TP53 mutant. And you also have non-Wnt, non-sonic hedgehog, which include group 3 and group 4 tumors. And you also have histologically defined, but really the focus of this presentation is the molecularly defined, which is really gives the prognostic information and a lot of the imaging clues, which we'll go into a little bit, how you can differentiate these different types of medulloblastomas. And this was just a kind of another summary that I had before that paper came out. What's also interesting, if you really dive even deeper into these medulloblastomas, if you look at the methylation profiling, there's actually multiple subgroups within sonic hedgehog. There's actually 4 subgroups. Within the non-Wnt non-sonic hedgehog, there's actually 8 subgroups in the 2021 classification. You can see here with the methylation profiling, the 8 subgroups, and they also broke it down in TP53 wild type and mutant. One of the reasons we'll go into is the prognostic information about that. And this is right out of this recently released Neuro-Oncology paper discussing the World Health Organization classification. So some of these subgroups are associated with clinical, pathological, and genetic features that provide clinical utility, having either diagnostic, prognostic, or predictive value. And one of the examples they gave was 2 out of the 4 sonic hedgehog groups, 1 and 2, are from young children, and there's significantly different outcomes. And these distinctions may be predictive rather than solely prognostic. So you can see the importance of us understanding these different molecular subgroups as well. And it makes it challenging. I will say up front, that's very challenging for imaging. The more subgroups, you have 8 subgroups of just non-Wnt non-sonic hedgehog, trying to get those numbers to produce reliable imaging findings is extremely challenging. It's already challenging enough just to differentiate the main groups of medulloblastoma. Some of the history behind it is kind of interesting. Cushing and Bailey actually first described medulloblastoma in 1926 and first described it as spongioblastoma cerebelli, and obviously that didn't stick. In 1953, craniospinal radiation was shown to be improved survival in a landmark study. So that was in 1953. And in the 1970s, chemotherapy was added, again, improving survival. And then in 2011, 2012, there was a consensus definition of the 4 medulloblastoma subgroups. So you can see in about almost 100 years, the 2016 classification was the first time that the World Health Organization actually included the molecular grouping into the classification. In 2011, 2012 is when they first actually had the consensus definition of them. So it took some time for us to get to this point. But now there's been an explosion of molecular details and understanding. And this is, this is a breakdown of the different subgroups. So you have the Wnt, and actually part of this is covered, so that's why I'm looking on another screen. But the Wnt tumors or subgroups are only about 10% of the medulloblastomas, but have the best prognosis, very good prognosis. And it's very rare for them to have metastatic disease. While the sonic hedgehog, it's approximately 30% of tumors, probably the most well understood as far as genetically genetically understanding them or molecular understanding of these tumors. Location of these is more cerebellar hemispheres. We'll go into that in the next slide. And when you look at group 3 and group 4, they make up about 60% of all medulloblastomas. And these actually have the worst prognosis and more likely to present with metastatic disease at presentation or with recurrence. And we'll go into now detail of each of these. Now, location, that's important. So within the color schematic here, the blue depicts Wnt tumors, which is usually dorsal brainstem, cerebellar peduncles. It could be also within the CP angle. But these tumor cells, unlike the other groups so within the Wnt, they're actually thought to be cells from the dorsal brainstem. The red represents cerebellar hemisphere, sonic hedgehog, which are usually in the cerebellar hemisphere, so not usually within the midline. And then you have group 3 in yellow depicted, which is usually superior vermian, close to the fourth ventricle, and group 4, which is most likely or usually inferior vermian. So that's why location is important, but as we get into the imaging, we'll go a little more. So here's an example. We're finally getting to some of the MRI, and I'll describe some of the sequences. So here's DWI ADC, showing a mass center in the fourth ventricle, shows reduced diffusion, shows enhancement. This is the post-contrast sagittal T1, axial T2. But just saying that this is likely medulloblastoma, the future is going to take a little more understanding of the molecular subgroups. So how can we improve on just saying this is medulloblastoma? Well, that's what we'll dive into, because one of the initial discussions was location might help us, that here's a Wnt tumor. It was thought that these could be primarily CP angle masses, right? Are they all cerebellopontine angle masses? Not really. I'll show that in the next few slides. Here's an example of a sonic hedgehog mass. Here's a T2 weighted sequence. This is in the cerebellar hemisphere. This is commonly where they're thought to be. Here's a group 3 midline and group 4 on the T2 in the midline. This is a T1 post-contrast sequence. So let's dive a little deeper into the Wnt tumors. Like I said, the least common, but the best prognosis. And understanding the genetic mutations behind this, the 90% of Wnt tumors have a mutation in CTNNB1, which encodes beta-catenin. And this is what actually activates the Wnt pathway and keeps it activated to cause these Wnt medulloblastomas. And here's a MR of a Wnt tumor. So you see it's a midline mass. That's the first thing where we said, are they always CP angle masses? Well, no, in this case, you have a T2, DWI, ADC. See how dark it is on ADC? That's usually what you see with the medulloblastomas. This is post-contrast showing enhancement, but this is the most important sequence of this case. This is an SWI sequence, which shows the susceptibility correlating with the hemorrhage. And we know on pathology or even in the OR, these tumors are more likely to have blood products associated with them. And part of it might be related to the leaky or fenestrated blood vessels associated with the Wnt subgroups of medulloblastoma. And let's look at this study, which is looking at multiple medulloblastomas. But what's key here is that these are all Wnt tumors. If you look at this, this is a midline mass, CP angle mass, cerebellar hemisphere, vermian, and then within the white matter. And it's also important to know that, so what we were saying, are they majority CP angle? Actually, majorities are not CP angle masses. In addition, the study showed that a lot of them had the susceptibility or blood products, and some of them, this is a T2 sequence showing cystic changes. So the more common findings that you might see with the Wnt tumor are blood products or blood and cystic changes, and they're not preferentially midline, so or just off the midline, because you see here, where we were thinking, are they all CP angle masses? Only 13% of these were. Out of 38 Wnt tumors, only 5 of them were out of the 38. Actually, a majority were midline within the fourth ventricle, 66%, and within cerebellar vermis, another 8%. So location is not as helpful with that as we thought it would be. And medulloblastoma, the next one we're looking at sonic hedgehog. Looking at this one, the most common mutations that you'll see are within the SUFU and the PTCH1. These are the generators of the more common genetic mutations that you'll see with sonic hedgehog. And the TP53 mutations are also important. That's why you see the breakdown in the World Health Organization classification of sonic hedgehog wild type versus mutation. And that's because the TP53 mutation has a much worse prognosis. It's considered high risk. And this is important when classifying the sonic hedgehog. And the reason, like I said, it's within the 2021 classification. And here's an example of a sonic hedgehog medulloblastoma with extensive nodularity, which is describing the histology. But why I included it in this is because here's the post-contrast sequence. Well, first, let me go over these sequences here. This is DWI. ADC shows reduced diffusion. Most of these sonic hedgehog tumors are within the cerebellar hemispheres, as you can see in this case. Here's the T2 sequence. But they also, when you have this extensive nodularity, it kind of actually looks like the imaging. It has this nodular post-contrast or enhancement pattern, and that correlates with histology in this case. Here's another example. This patient actually had, this was actually a 1-year-old with sonic hedgehog tumor and had desmoplastic nodularity. Sorry, this slide got modified slightly when I moved the presentation to a Windows computer. But this is actually 3 different slices of the DWI sequence. This is a more inferior slice showing a mass. There's a separate mass more posterior and another mass on the DWI. I see that bright signal there. And that's actually seen here on the post-contrast sagittal T1. So you have a larger mass inferior, a few more masses posterior, and another mass posterior. And this is just a coronal T1 post-contrast. And this was an example of a multifocal presentation of medulloblastoma. In these cases, you should think of Lee-Fermeni syndrome or Gorlin syndrome that can predispose to this multiple medulloblastomas or other tumors. In this patient, the genetic workup was still being done, but with this type of presentation, with this age, that's definitely part of the workup, is to have a genetic and also history of, a family history of tumors might help in understanding what kind of syndrome the patients are presenting with. And now we'll go to group 3 and group 4 tumors. What's important here again is that these have very poor prognosis, more likely to have metastatic disease. And the MYC amplification, this is a group 3. The only thing I want to take away from this slide is the MYC amplification, which in a group 3 tumor is going to have a much worse prognosis or a high risk group. And here's an example of an MRI in a group 4 tumor. So what you can see here is on the post-contrast axial T1, there's minimal enhancement. Here's a sagittal post-contrast minimal enhancement. So these tumors in general have less enhancement than the group 3 tumors. Here's a DWI sequence, a lot of reduced diffusion. But the most important sequence for this is actually the MR spectroscopy. There's a peak here at 3.4 ppm, which correlates with the taurine peak, more commonly seen in group 3 and group 4 tumors. Here's a different patient presenting. So at my prior institution, we actually didn't differentiate group 3 and group 4. Prognosis was similar and treatment approach was the same. So you can see here, here's a DWI sequence showing a mass, again, 4th ventricle, ADC, showing the reduced diffusion. Post-contrast, there's enhancement of the mass. But this is not why I'm showing this case. This patient presented with metastatic disease throughout the spine. Here's your sagittal post-contrast. You can see all the enhancement along the cord. But the most interesting thing of this patient was actually axial post-contrast imaging of the spine showed all these enhancing lesions within the liver. So here's the liver, 2 different slices showing all these enhancing lesions. These are actually multiple metastases from medulloblastoma. And you can actually have extraneural mets in medulloblastoma, more likely in group 3 and group 4 tumors. So keep an eye out on your post-contrast imaging when you're getting that axial through the spine to look at organs, primarily, usually, I would say usually it's not that common, but the liver would be a site of attention. And when you think about medulloblastoma metastases, you usually think about CSF spread or leptomeningeal spread. But cases like this prove that hematologic spread, and other studies have supported this, hematologic spread is actually one of the causes of metastatic disease, and likely more common in group 3 and group 4. I haven't had enough evidence to support that enough. Haven't seen enough studies to say that for sure. And when you think about protocols, MRI imaging, the Rapno criteria for medulloblastoma is a very good reference. These are the essential sequences that should be obtained when imaging medulloblastoma. And you can see here, axial flare, post-contrast through the brain. That's important. But what I want to show also was the spine imaging. So when you get spine imaging, the actual CIS sequence or Fiesta sequence is an important sequence to look for metastatic disease. And here's an example from this paper here, where you can see these nodules or T2 hypotense lesions on that sequence. So it's a very high resolution sequence. This is correlating with the enhancing metastatic lesions along the cauda nerve roots. There's an axial, but again, I think my screen.
John, can you try and sort that out? It seems as though somebody else is.
Yeah, you're just starting the screen share. It could be the bandwidth issue is kicking in. Try to screen share again. Leave.
I think someone else. Yeah, I got it back. I think someone else might have tried to share the screen at the same time.
Yeah, try it again. Try to enter. There you go. There you go.
Okay, perfect. And the importance of this is this sequence, the CIS sequence or the Fiesta sequence. The importance of that one, which is also called the balanced steady state free precession sequence, is a lot of times you might only pick up the metastatic disease on this sequence and not on the post-contrast. This is the post-contrast T1, where you're seeing the correlating enhancement of this metastatic lesion. And again, you're seeing the correlating enhancement of this lesion here along the nerve roots. But there are cases I've seen where you can only see it on this CIS or Fiesta sequence. So I do think it's important to keep in the imaging protocol. And another important thing, like I mentioned, the MR spectroscopy, there's a taurine peak. This is back in 2006, Dr. Panagrahi and team. That's actually, I was working with Dr. Panagrahi at the Prime Institution. He did some amazing work on MR spectroscopy in medulloblastomas. And what they knew in 2006 was some of these medulloblastomas had taurine peaks and some did not. So here's this 3.4 ppm taurine peak and the choline right here at 3.2, and then creatine at 3.0. So taurine's at 3.4. But then as the molecular understanding of these tumors became more clear, so this is now 2016, it was clear that certain subgroups have taurine peaks and some don't. And this is again, group 3 and group 4 were the ones demonstrating this taurine peak, and the sonic hedgehog is less likely to demonstrate the taurine peak. So this could be a useful tool to help differentiate these subgroups, actually. And I've seen cases in actual clinical practice where it became helpful. This is just a nice summary of everything we've seen or discussed, where you get from surgical resection to pathology and you get to the staging. So when you're with the Wnt tumors, like we mentioned, excellent outcome. Either way, whether it's average or high risk, you're gonna have an excellent outcome. And it's important because when I discussed this with neurosurgeons, they would like to know if they were dealing with a Wnt tumor or sonic hedgehog pre-surgically. That would help them to be, and this is just a discussion, no official survey or anything like this, but it seems like neurosurgeons would have a less aggressive approach with Wnt tumors if they felt confident with the pre-surgical diagnosis on imaging. Sonic hedgehog, we mentioned the TP53 mutation puts you in a higher risk or poor prognosis. So here's sonic hedgehog, TP53 mutation. This will be like a wild type, so a better prognosis. Non-Wnt, non-sonic hedgehog, we mentioned the group 3 or in general non-Wnt. If you have the MYC amplification, it's a worse prognosis compared to this group over here, where you have a better prognosis. And this is just another way to look at it. Clinical risk categories, very low risk, Wnt, no metastatic disease. That's something we are trying to stress. Sonic Hedgehog, TP53 mutants, that puts you at a very high risk group, as well as group 3, MYC amplified, and group 3 with metastatic disease. So, and there's a spectrum as you go through, and another way to look at it, I won't go into this graph over here, but I like this to kind of summarize everything that we've mentioned, and also the syndromes, just to close it out. We saw a patient earlier that likely had syndrome, possibly Gorlin syndrome, which these patients present with like a basal cell carcinoma, and then you can also have a leaf for many syndromes. So these are the most likely to present with medulloblastoma, or the highest risk groups. And I like to close it out with saying, I think the future, as we discuss such a detailed discussion of medulloblastoma subgroups and molecular details, that radiomics and radiogenomics will be an important role in radiology in the future, and also including AI and deep learning models to help all this tremendous amount of data that comes out of it. There's not enough time to go into the radiomics or radiogenomics, but all these imaging futures, I do think will be at least worthy of studying in the near future to help us classify these tumors a little better, especially as you can see the subgroups. If there's 8 subgroups, in addition to the main groups of medulloblastoma, we might need some help with radiomics being that answer, hopefully. So I can thank again all the organizers for this opportunity, and happy to take any questions.
Right, thanks, Ashim. There was a really great overview. I think radiomics really plays a part treatment strategy. John, do we have any questions posed? I can't see anything in the chat though.
Okay, I haven't scored anything.
No.
All right, perfect. Thank you.
Well, I'm going to ask you a question, Ashim, quickly before you head off. So
I'd raised my hand as well, so you know.
Oh,
Okay, I'm sorry, I missed that.
No problem.
Go
Go ahead, Lou.
Okay, so just a quick question. I mean, you showed how beautiful the MR spectroscopy is if it can be interpreted, you know, appropriately, the taurine peak, the tau peak. The role of nuclear imaging, you know, so PET CT. One of your scans did show, I think it was a PET CT that you showed. Do you think that has a role to play in sort of, you know, the broader extended radiomics or nuclear radiomics?
Yeah, oh, actually, one of the color images I showed was an AS arterial spin labeling, so it was showing increased perfusion. But I see what you're saying. It does remind me of PET imaging. I do think PET imaging is going to be a very important imaging tool in the future, especially when you're looking at molecular targets, where you can more specifically target imaging or like using theranostic agents to look specifically for those molecular subtypes of tumors. I think that is definitely going to be a huge role in the future, and also looking for metastatic disease. It's probably going to be an important role, and we're getting more. There are groups in like the prior institution I was at, University of Pittsburgh, investing a lot into PET agents and more specific imaging biomarkers. So I think that's a very promising future.
Right, thanks. Mood, I see you did the...
Yeah, but you kind of read my mind. You asked the exact same question that I was thinking about PET and its role in diagnosis. So yeah, great. Across the continent, we were thinking exactly the same thing at the same time.
And actually, whole body PET and the radiation doses of these new agents are so low that I think it's making it easier for people to apply them. And I mean, at least there has to be some more investigation to this, but I think this is allowing for those investigations to be performed at easier scale, and this will set us up for using these agents in the near future, hopefully.
Great.
Thanks.
Exactly. Thank you. That was the exact same question. Yeah.
Thank you.
We've got another hand raised there, Ozgur Ismailoglu. you want to ask a question?
That was a
Oscar?
mistake. That was a mistake.
Was it a mistake? All right.
Yes.
So Mo, any comments? And then maybe Nassim?
Thank you, Ashim, for this nice presentation. Actually, it's really difficult in imaging of brain tumors in children. So my question was about the MR spectroscopy again. How beneficial do you find the MR spectroscopy in brain tumors in children when to differentiate between low grade and infections? If there is any role for this?
Yeah, so I think there was a differentiate low grade versus, you said your question was low grade versus like high grade or infection?
Inflammatory or abscess or infections.
Oh yeah, that's what you're saying. Yeah, that's a good question. I have a long presentation on MR spectroscopy that I do think it's important in certain cases. And I think it's important to perform consistently, because if you're only performing MR spectroscopy as advanced, I mean, I don't even consider it advanced technique anymore. It's been around so long that it's something that needs to be done consistently to be familiar with it. So if you see it in a case just once in a while, it's hard for that radiologist to really grasp the importance of the spectral profile in that case. So I think if it's done consistently, you get familiar with your technique at your institution. When the time is needed to implement it and use it for diagnosis, that's when it comes in handy. And so it can help in cases of encephalitis versus tumor. So we have like a multifocal type of infiltrative tumor. It might not necessarily be low-grade tumor, but it might be an infiltrative high-grade tumor. A lot of those sometimes look like encephalitis. I've had at least 2 cases where, I mean, I felt like the case looked like a multifocal tumor. Someone thought it was encephalitis, and MR spectroscopy in that case can differentiate or help in those cases. It's not perfect, but again, like I said, if it's done consistently, can be implemented versus abscess specifically. It should. It's not something I've used specifically for abscess, but I think the D-to-AI sequence in that case is a more helpful enhancement pattern. But I think in general, it does have its cases where it can be, MR spectroscopy at least, helpful.